Right, cool. Let's do the diverticular abscess. I think we missed this last time, but basically for diverticular disease, they can ask you the question that we asked last time and then continue into diverticular abscess, if that makes sense. All right. So we should have added this to the scenario from last time. So a 75-year-old female patient presented with left inferior quadrant abdominal pain and tenderness, and she was acutely unwell and was admitted to. What's your differential diagnosis with left inferior quadrant abdominal pain?
So my differential diagnosis here would be diverticulitis, diverticular abscess, a ruptured diverticulum, bile obstruction, adhesions, sigmoid volvulus, constipation, colorectal cancer, and I'd also consider renal causes such as renal colic or pyelonephritis.
You'll be given an ABG and you'll be asked to interpret the results. What's your method of doing this?
So I think the ECG for this scenario is metabolic acidosis with partial compensation. I'd want to know the P of the patient, and also I'd want to know most importantly, the bicarb, and I'd try and differentiate if it was a respiratory acidosis or a metabolic acidosis.
And how would you like to do that?
So I would like to look at the pH, so it'd be less than 7.2. I'd want to know the bicarb result. If it was within normal range, that would show that it's compensated. And also then I would then go ahead and then look at the PCO2 to see if that was raised or normal.
So if pH is reduced and PCO2 is raised, what does it mean?
So if pH is reduced and
PCO2,
is that raised or normal?
So PCO2 is raised and pH is reduced.
That'd be respiratory.
So your stepwise approach in identifying the the ABG findings. First thing, you're going to look at the pH to decide if this patient has acidemia or alkalemia. All right,
Okay.
rather than acidosis and alkalosis, acidemia and alkalemia, because this is the presence of hydrogen ions in blood. So acidemia or alkalemia. That's first step. Second step is actually looking at the CO2. All right. This will tell you if it's respiratory or metabolic, and whether there is any respiratory compensation or not. If CO2 is reduced or less than 4, so you're looking into very likely metabolic acidosis and with some respiratory compensation. If CO2 is normal, so it's a metabolic acidosis and there is no respiratory compensation just yet. If CO2 is high, this is respiratory acidosis rather than metabolic acidosis. After CO2, you look at the bicarb. And you will decide if it's metabolic or respiratory with compensation. Based if the bicarb is low, so that's metabolic acidosis. And then bicarb is high, that likely means that the patient had respiratory acidosis with high CO2 and some compensation from the metabolic side. And then you're still in ABG, you would like to look at some other electrolytes, and that include chloride, and that includes sodium, potassium, and magnesium as well. ABG, you can also mention that ABG can give you a quick finding on the hemoglobin and glucose level as well. All right, fine. How would you define shock?
So shock is a acute circulatory failure which causes inadequate perfusion to tissues and causes tissue hypoxia.
What kind of shock does this patient have?
And this patient would have septic shock, which is profound circulatory failure in multiple systems, and it causes metabolic abnormality. An example of septic shock would be a patient that's persistently hypotensive and secondary to multiple fluid challenges, or they would also have a persistent lactate above 2 despite having adequate resuscitation, and also I think having a pulmonary or a wedge pressure above 65 in the absence of vasopressors or with the use of vasopressors.
And how would you like to manage this patient in terms of first investigation and then management?
So I'd like to manage this patient according to CRISP protocol using ATUE approach. I'd ensure that patients know by mouth. Also consider using a NG tube to decompress the stomach. And then like to proceed by non-invasive and invasive methods. So here I'd like to request a CT, thorax, abdomen, and pelvis. Then based on that, can use the Hinchey classification. Given the fact that this patient has a diverticular abscess, it's likely to be Hinchey 1 or 2. You can be managed either by open drainage or by the insert or image guided with interventional radiology. The advantages of open drainage is that we can do a ample or adequate washout, good peritoneal toileting, and also the ability to form a stoma. However, there is a higher risk of infection, and it's likely associated with increase in mortality and morbidity. The image guided drainage is a minimally invasive procedure. It will allow the involvement of a pigtail catheter for continuous drainage post-operatively. However, large volume drainage cannot be performed, and it's not suitable for the production of a stoma.
What are the investigations that you would like to offer to this patient?
So here the investigations I would like to do would be a CT abdomen and pelvis, which is the gold standard. Other things that I could do would be a ultrasound scan. Could also consider doing a barium enema. I wouldn't do a sigmoidoscopy or colonoscopy in the presence of acute disease at present, as there is risk of perforation, but would consider doing that as a patient deteriorated in an elective scenario after.
That's fine. So I've asked the question twice. What I was trying to get at is that you established a very good differential diagnosis initially. So you would like your investigations to cover that differential diagnosis, right?
You wanted a abdomen and plain X-ray or plain radiograph of the...
So you want to start from the beginning. You want to do some bedside tests. What are the bedside that include ABG, which you've already done?
So here I'd want to do, first of all, I'd like to do some bloods to rule out... First of all, I'd like to approach this patient considering sepsis 6 protocol. Want to take some bloods, including a full blood count, using these LFTs and CRP. Also like to do an ABG, including a lactate. I'd also consider starting the patient on IV antibiotics according to local trust protocol. And then the non-invasive imaging techniques I would do would be a CT of the abdomen and pelvis, ultrasound scan, and barium enema. And the invasive procedures I would consider would be doing a colonoscopy or sigmoidoscopy as an elective procedure later on.
Good. That's excellent. I think, Ravi, you're doing really well, as I mentioned before, but I think that one point to keep an eye on in an exam setting, it looks like your curriculum very well, but an issue that you might face is actually understanding the examiner question, given that you already know the curriculum very well. All right. And this is what I've noticed in my exam. So it happened at least twice during my exam that I've started answering question, and after taking a minute answering the question, the examiner would repeat the same question or paraphrase it, and I have to read the answer. It's because that I'm very, obviously during that exam, if you know the curriculum well, you would feel very confident, you'll be very ready for every question, and you'll be very excited to answer, and that will end up not on your benefit sometimes. So one thing is so basically I've asked you a very clear question, but I basically changed the phrasing of this, and I said, what are you going to do for this patient in terms of investigations and management? So you want to take from my words, in terms of investigation, I would like to do some bedside tests to cover my differential. That will include an ABG, CG, etc. And I'm sure you will answer it very well, but the key one is just actually to actively listen to your examiner, because things can change, all right? It will not change dramatically. There will not be dramatic change. They can just paraphrase a few questions, but you have to listen very carefully to the questions, all right? The definition of shock, you've made a good definition. So it's a state of reduced end organ oxygenation due to imbalance between the delivery and the demand. The type of shock that this patient had could be a septic shock, and that's why I would like to start sepsis 6 and the management.
That's a key word here, isn't it? Yeah. Do you think I should mention the whole hypertension after fluid resuscitation, lactate persistently over 2 despite resuscitation, and...
Of course, you can mention that, 100%. As you can see, the scenario is short, but it doesn't come on its own. So it will come diverticular disease and then diverticular abscess as a single scenario. So we would definitely have more questions in this one.
I see.